to talk little on osteosarcopenia, an evaluation in understanding osteoporotic fracture. All of us have been knowing osteoporosis for more than a century now, but unfortunately, little has been known about sarcopenia and osteosarcopenia, which is equally important, if not more important, in orthopedic practice, and especially for the elderly generation. The most important success of older adults is maintaining a good physical status and functional status, and at the same time remaining continent. And these are the pleasures of life which you have to enjoy in your senior or elderly life. The musculoskeletal system is strong enough to withstand physical activities, and for the balancing act, we need a neuromuscular system, which is absolutely, it has to be intact. Your proprioception has to be intact. Your balancing system has to be good, and it also stores the calcium. The bone stores the calcium, which is very important metabolically for day-to-day function. The longevity with good activity maintains good physical and functional status, and the longevity with minimal activity has a hefty penalty to pay in case if you have problems like osteoporosis. The osteoporosis with trivial fall can result in fracture, which can lead to plenty of disability, morbidity, and sometimes mortality too. So we have for centuries. So basically, osteoporosis has been defined by Palmer way back in 1895, and he described it like as a disease of elderly with fragility fractures and their complications. So why not pick up osteoporotic for a person before they actually develop a fracture or before they start losing height? And this is the crux of the whole preventive aspect of managing osteoporosis and also managing the muscle imbalance, muscle problems. The determinants of bone strength are genetic, race, and gender, which are unavoidable and we hardly have any control on them. But smoking, excessive alcohol, deficiency of sex hormones, having a thin and lean demeanor, chronic calcium and vitamin D deficiency, and sedentary lifestyle are avoidable things which has to be avoidable. In a lighter sense, if your father is poor, you are unlucky. But if your father-in-law is poor, you are stupid. So you don't have to be stupid to manage all this osteoporosis, and you have to take care of all these deterrents which you have to prevent. Soon people realize that BMD is not the only determinant of fragility fracture. Bone quality is also important, and that's the reason FRAX tool was introduced. And this actually tells us the possibilities of fracture in future, and which can actually predict who and how and when one can have a fracture in future. The fractures are main clinical consequences of osteoporosis. And if you see the burden of this in India, there are more than 1.5 million osteoporotic related fractures per year, out of which hip fractures constitute almost 300,000, vertebral fractures are 700,000, wrist fractures constitute almost 250,000, and other fractures are 300,000 fractures. So you can imagine the burden that has on the medical and the health expenses of India. We also know that 1 in 2 women and 1 in 5 men over the age of 50 will suffer a fracture in their remaining lifetime. 55% of the persons over the age of 50 are at increased risk of fracture due to low bone mass. And if you can see this age-related changes in the femoral neck cortex and association with hip fracture, at the age of 20-year-old and at the age of 80-year-old, you can see this cross-section of femoral neck, preferential thinning of the inferior anterior cortex is seen and increased cortical porosity. And that's the reason why in the fragility fracture patient assessment, history should also include the family history of osteoporosis, onset of menarche or menopause, the nutritional status of a person, medication like taking medication for hypertension, diabetes, and other metabolic problems, level of activity the person has, the fracture history, fall history, and the risk factors for falls, whether he takes alcohol or smokes, whether there are risk factors of secondary osteoporosis, finding out any metabolic problem, and prior level of function. So there are a host of laboratory tests which are required. The basic tests are calcium, phosphorus, alkaline phosphatase, and vitamin D estimation. And there are some specialized tests which are required to find out there is a possibility of a secondary osteoporosis. BMD, of course, is a current gold standard for diagnosis of osteoporosis, and this has to be done in most of the cases where we are actually going to start the treatment for osteoporosis. So the ideal would be to prevent falls, which is absolutely important, decrease the chances of fracture after the fall, and improve the outcome after the fracture. And this is extremely important. So we come to a very important topic of sarcopenia, which was defined according to the Asia Working Group of Sarcopenia criteria, in which the assessment of walking speed and grip strength is done, and at the same time finding out if there is diabetes, chronic kidney disease, stress, poor physical activities, or poor nutrition is there. The symptoms and signs include a decrease in muscle mass, weakness, loss of endurance, poor balance, and trouble climbing stairs. And all these are very important. Even if there is one or two which are present, which should always suspect if the person has got sarcopenia, especially in the elder group. So, what is the association between sarcopenia and osteoporosis? Sarcopenia was associated with threefold high risk of osteoporosis, and this table will tell you how this risk increases. How do you check? We do a skeletal muscle mass index, in which the sarcopenia there is a low muscle mass, which I have already spoken, below 5.4 kilogram per meter square in women and below 7 kilogram in meter square in men. And this should arouse a suspicion of sarcopenia or having muscle mass which is low. Binkley and Buring in 2009 gave a very good terminology of osteosarcopenia, because they exist each other with each other in many of the cases. A subgroup of frail older patients with higher risk of falls, fractures, and disability and frailty, and this is in fact uh, basically osteosarcopenia, and which is seen in many of these which are combined together. So, in which Boring said that hip fractures and sarcopenia, there are 300 women with hip frailty fractures were seen. 58% were also sarcopenic. The men aged more than 65 years, there was a fracture risk which was 3.5 times more in osteosarcopenia versus only sarcopenia or osteopenia alone. So this is a measure of problem or consequences of both these together. And this is a Korean study where they said osteosarcopenia in patients with hip fracture is related with high mortality, in which they said, and they checked 324 elderly patients. In females were 246, males were 78, and in which the normal fractures were about 20%, only osteoporosis was about 43%, sarcopenia was 9%, and osteosarcopenia constituted about 29%. The mortality at 1 year in males in osteosarcopenia was about 26%, and in non-osteosarcopenic patient was 2.1%. So you can imagine it is almost 10 folds more mortality when the patients have osteosarcopenia. So prevention and the treatment of osteosarcopenia includes also physical activities, some kind of exercises, and in India, yoga and meditation really is a very good part of it to have your physical strength. And there is also very important part, which is dietary proteins, which is a very important role in maintenance of the musculoskeletal integrity. Healthy older adults are still not taking adequate amount. At the same time, we must remember that excessive intake of protein may also lead to some adverse effects. So we have this fantastic four, which is very important for osteosarcopenic treatment: calcium, vitamin D, and phosphate, that all of us know, but protein, which also constitutes a very good important ingredient of your diet. So we have one excellent example in Mumbai Orthopaedic Society, who turned into 5 years from a flabby young gentleman to a very strong, healthy, very strong muscles individual. And this can happen, and this can is possible with any individual with proper diet, with proper intake of calcium, vitamin D, proteins, etc. And we are going to talk about one more product which is also important for getting those muscle strength. So these fantastic fours are very important. At the same time, exercises, maybe dancing if you like, but some kind of uh, exercises which are day to day, every day, sincerely and honestly done are important. So what are the criteria for diagnosis of sarcopenia? The first and foremost is low muscle mass, low muscle strength, and low physical performance. And for that, we have our MRI to our rescue, or finding out actually objectively how this muscle mass is reduced. So we have in this a cross section of leg or thigh muscles, in which we can see the age of 25 how these muscles are looking, and at age of 63 the same person with sarcopenia, these muscles are grossly wasted and thin. Similarly, in the spine and paraspinal muscles, if you can see at the age of 25 how these muscles look, and at the age of 63 they are grossly inadequately helping the spine to balance. How do you diagnose sarcopenia? So we have older subjects which are more than 65 years. We measure gait speed, we measure grip strength, and we measure muscle mass. And this is an algorithm which can help you to find out whether there is any sarcopenia or no sarcopenia. And the diagnosis of sarcopenia mainly is finding out the muscle mass, the muscle strength, and physical performance. In muscle mass, we can do CT, we can do MRI, we can do DEXA, we can also do specialized tests like bioimpedance analysis, we can also do total or partial body potassium per fat-free soft tissue. These are very important to find out the muscle mass. We also can see the strength by checking hand grip strength, flexion and extension at the knee strength, the peak expiratory flow. So we basically check hand grip strength in most of these cases. And in physical performance, there are specialized things that we check. We usually check the gait speed. We do timed get up and go test. There is a stair climb power test. And important is SPPB, or short physical performance battery. So these are very important to find out how the mass, strength, and body performance or physical performance is, to find out the sarcopenia. Now, what are the causes of sarcopenia? There is primary sarcopenia, which is essentially age-related sarcopenia. There is no other cause evident except aging. And there is a secondary sarcopenia, which is activity related. Basically, person who is taking bed rest, has a sedentary lifestyle. So this or a zero gravity condition can give rise to this secondary or sarcopenia. If second is disease related sarcopenia, which is associated with chronic debilitating conditions like COPD, tuberculosis, osteoporosis, if there is a major surgery which has been done, injury or critical illnesses or burns. And there is nutrition related sarcopenia, which results from mainly malabsorption syndrome, gastrointestinal disorders, or use of medication that cause anorexia. So these are the causes, these are the primary and secondary sarcopenia which we see in practice. There are various treatment options that we see, which is also good for osteoporosis. We have seen biphosphonates, denosumab, teriparatide, SERMs with a decreased risk of breast cancer, like raloxifene, and hormone replacement therapy. Calcitonin used to be used, but now no more longer used nowadays. And important that we are going to talk about is nandrolone decoinate. For use, I'll use nandrolone only as an adjuvant to specific treatment and dietary measures. So this is a very important, and I'm going to talk about it in few slides. The nutrition, as I told you, is very important, which has a beneficial factor. We have lots of micronutrients having these different molecules. We have magnesium, phosphorus, potassium, vitamin C, etc., which are very important, as good as copper, calcium, selenium, zinc, etc. also. But at the same time, there are potentially detrimental dietary factors which should be avoided at all costs. Excess alcohol, excess caffeine, excess sodium, fluoride, phosphorus, all these are detrimental to your health, especially for the bones and for the muscles. So the take home message would be in osteosarcopenia: encourage all your friends, family members, and patients to improve physical activity. Longevity with poor physical activity leads to sarcopenia, and poor BMD plus sarcopenia will result in osteosarcopenia, which may result in increased risk of falls, fractures, morbidity, and poor outcome, sometimes even mortality. So now we talk about nandrolone for the use of helping to prevent this sarcopenia and osteoporosis. This is useful in postmenopausal osteoporosis. It increases BMD at lumbar spine and femoral neck. Significant improvement of lean body mass and muscle mass is seen. Reduced incidence of new vertebral fractures up to 50%. And radial BMD shows mild improvement. It is also useful in relieving bone pain. All these are very important uses of nandrolone. So what is the recommended dose of nandrolone in our practice? It is used as an adjuvant to specific therapies and dietary measures in pathological conditions. It is used as 25 to 50 milligram intramuscularly, especially given deep intramuscularly, every 3 weeks, up to 5 doses. There are various myths about nandrolone, and I'm going to tell you the facts, and I'm going to prove that these are myths. Nandrolone decoinate is similar to corticosteroids, is a myth. Actually, it is not true, because corticosteroids are catabolic steroids, whereas nandrolone is an anabolic steroid. Corticosteroids increases the bone loss and have high tendency of bone thinning, whereas nandrolone increases the bone mineral density and is useful as an adjunct to specific therapies and dietary measures in management of osteoporosis. Steroids lead to muscle wasting, whereas nandrolone lean body mass and muscle strength increases. There's another myth that nandrolone cannot be given in diabetic patients, which is absolutely wrong, because in normal non-diabetic patients, nandrolone actually doesn't hamper the glucose tolerance when used at a therapeutic dose. In diabetic patients, nandrolone can improve the glucose tolerance and also has the metabolic effect on anabolic, may decrease the blood glucose. That's why it is important to decrease the requirement of insulin and other hypoglycemic agents. Thus, it requires glucose monitoring on frequent intervals, because it can also cause hypoglycemia, which is not desirable. Other myth is nandrolone is not safe in cardiac patients, which is wrong, because the fact is, in healthy men, nandrolone does not significantly change cardiac functions. Also, it has impact on lipid profile. It does not influence lipid parameters such as triglycerides, cholesterol, lipoproteins. But it is important to monitor BP and lipid profiles before initiating the therapy, during the treatment, and after completion of therapy with nandrolone. Another myth which is commonly seen is nandrolone has high androgenic side effects because it is anabolic steroid. But in effect, we have seen some kind of androgenic effect like mild virilization of hair growth or hoarseness in voice in females when administered beyond recommended dose. But this effect can be reversed once the treatment is discontinued. And this is one fear that women have in using this very good uh, treatment for osteoporosis and sarcopenia. Nandrolone, one another myth is nandrolone can cause edema or water retention, which is also wrong. The fact is, nandrolone had an overall positive effect on fat-free mass without expanding the extracellular water. in COPD patient. And this is very important. And this all these so-called anecdotal myths have been proved to be uh, factually wrong. There is one other myth, that does nandrolone cause cancer, which is a very absurd kind of myth. In fact, nandrolone does not induce increase in prostate tumor markers, but it's contraindicated in prostate cancer patient. And this is very important because we do not give any anabolic steroids or anabolic agents in prostate cancer patient. And this is very important because not true, because nandrolone increase does not induce increase in prostate tumor markers, but it's contraindicated in prostate cancer, which is important. So friends, we know the good effects of nandrolone, which is given as an anabolic steroid in cases of sarcopenia. And we have been using this for almost 40 years for osteoporosis, because we did not have many drugs or medication for osteoporosis before. And since my residency days in 77, we have been using this, and we have found that to be extremely useful, especially in the patients of osteoporosis and sarcopenia. And patients are able to have a normal, good strength even in the elderly age group. And it is mandatory, and we are obligated to give them good life even in the 70 and 80th age and the 7th and 8th decade. So it's important that we give them good drugs, good diet, good calcium, vitamin D, phosphate, and proteins, and along with that, give anabolic steroids maybe once a year, a dose of 5 injections. Thank you very much, friends, and over to you, Dr. Neeraj,